Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the Saudi Society of Pediatric Dentistry webinar. This is Linda Mirza. I'm a pediatric dentistry consultant at King Abdullah Medical Complex in Jeddah and one of the board members of the society. I would like to welcome you all to this 11th webinar of the society. This webinar is organized by the SSPD in cooperation with Kunuz Ritaj Company, Communication and Event Management Company. It's my pleasure to moderate this session tonight with Dr. Saad Al-Mania. Dr. Saad is a joint assistant professor at the College of Dentistry in King Saud bin Abdulaziz University for Health Science. He's a pediatric dentistry consultant and the chairman of the Pediatric Dentistry Division in King Abdulaziz Medical City, a Ministry of National Guard, and he is a board member of the Saudi Dental Professional Council and the Saudi Commission for Health Specialties. Good evening, Dr. Saad. It's an honor to have you with us tonight.
السلام عليكم ورحمة الله وبركاته. شكرا دكتورة ليندا على التقديم الجميل. وفي البداية بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. أتقدم بالشكر صراحة لمجلس إدارة الجمعية السعودية لطب أسنان الأطفال وبما يقومون به والحراك اللي نشوفه الفترة السابقة، يعني صراحة مجهود يعني رائع وواضح للناس جميعا، وإن شاء الله من كذا وأكثر. وريلي واشكر الحضور اليوم لحضور very interested topics today, and I think it's going to be a very rich evening today, and it's my pleasure and honor to be one of the moderator in the sessions today. Thank you so much دكتورة and for all.
أهلا وسهلا فيك دكتور، الشرف لينا لوجودك معنا، وبإذن الله الكل بإذن الله يستفيد مع الكوكب الرائع من الأطباء الموجودين معنا. So let me introduce for you our first speaker tonight, Dr. Shayma Al-Tayyib. Dr. Shayma is a pediatric dentistry consultant at the Pediatric Dentistry Department in King Fahd Armed Force Hospital in Jeddah. She will talk today about a very interesting topic, which is the prevalence of molar-incisor hypomineralization, a literature review and standardization of prevalence studies. Dr. Shayma will talk to us about the prevalence of MIH in the world, especially in Saudi Arabia, and she will explain for us the difference between the studies that conducted about MIH in Saudi Arabia. Before I give the mic to Dr. Shayma, I would like to highlight that if you have any question, just please feel free to write it down in the bottom of that screen in the Q&A section. We will answer them at the end of each presentation. And I really wish that you will have a great time. Dr. Shayma, the mic is yours. I wish you all the best.
Thank you, Dr. Linda, for this kind introduction. Thank you, Dr. Linda, for this kind introduction. I'm proud to be a member of the Saudi Society of Pediatric Dentistry, and I'm honored to be given this privilege and to be a presenter during this night. I'm Dr. Shayma Muhammad Tayyib. I'm a consultant pediatric dentist in King Fahd Armed Forces Hospital in Jeddah, Kingdom of Saudi Arabia. My lecture for tonight is about the prevalence of molar-incisor hypomineralization, a literature review and standardization of the prevalence studies. The outline of my lecture will be as following. I'll start by an introduction, then I'll have a brief literature review, followed by prevalence of MIH worldwide, a global prevalence of, from systematic reviews, and prevalence of MIH in Saudi Arabia. Then we'll shed some light on certain topics like the need for term modification, need for standardization, suggested standardization protocol, and the index of MIH and hypomineralized second primary molar, and the validity and reliability of this index, and how to apply the protocol, and we'll wrap up by conclusion. So to start with, we have a raised concern about MIH worldwide. We don't have a scientific meeting, a dental conference. They keep discussing that over and over. We can explain that in the European countries that they have decline in the prevalence of dental caries and a new problem has arisen in the past 20 years. But in a country like Saudi Arabia, where dental caries is still shooting high and prevalent, why do you have to be concerned about MIH? Are we just following the lead, or this problem is contributing to the high numbers of dental caries? So to answer that, we have to know, we have to quantify the problem. We have to know how common it is. And to know that, we should have prevalence studies that we can rely on them. We have conducted a literature review using PubMed searching engine for all the articles published in the past 20 years. Around 80 studies were reviewed. The included studies, they contain the term MIH and prevalence in the title or in the abstract. They were reviewed as full text or the abstract only. From our review, we had the following findings. MIH is more common in first permanent molars as compared to incisors. It's common in maxillary incisors as compared to mandibular incisors. It's more common in maxillary central incisors as compared to maxillary lateral incisors, but it's more common in the mandibular lateral incisors as compared to the mandibular central incisors. There's no difference between the right and left side. Regarding which is more common, the maxillary or the mandibular first permanent molars, we have conflicting results. Some of the studies say that the maxillary first permanent molar is more common, others say otherwise. Regarding also which is more common, the less severe lesion without post-eruptive breakdown or the well-demarcated white opacity, also we have conflicting opinions about that. There's no sex predilection, and it's more common in subjects below 10 years of age. Many studies have correlated MIH with socioeconomic status and water fluoridation, but no correlation was found. Regarding the prevalence of MIH, we have wide disparity between studies. It ranges from as low as 0.48 in a study conducted in India, in Bangalore city, and as high as 44% in a study conducted in Australia. Regarding the pooled global prevalence, two systematic reviews show results of 11 and 14%, which means that more than 800 million person or subject are affected with MIH, which is a huge number. Regarding the prevalence of MIH in Saudi Arabia, we have 4 studies about that. The first conducted in Jeddah by Dr. Al-Lizam and his working group. It gave a result of 8.6%. 2 studies conducted by Dr. Al-Hamad in Riyadh region and gave results of 40%. And the last study by Rizk et al., it was conducted in 7 cities in Al-Qasim region and gave result of 25%. So as we can see, we have wide variation between the studies. Even the studies conducted in the same country in Saudi Arabia, we have wide variation. So why is that? This could be related to actual differences in socio-behavioral differences between different countries, different environment, different genetic and ethnic groups. And this also could be related to the differences in study design. In a literature systematic review, by L. Frank and his working group in 2015, he listed a number of differences in the study design. So as we can see here, he reviewed the articles about the prevalence of MIH in the past 30 years. We have wide variation in the prevalences. One of the reasons for that is differences in the diagnostic criteria. Difference in the sample size. It ranges from as low as we can see here, 25 subjects to thousands. The age of the subjects, it's wildly variant from 4 years of age up to 17. Some of the studies, they selected the population, others, they did not do any selection. And most of the studies were conducted in cities, but some of them, they were conducted in rural area. And also the calibration of the examiners is, some of them, they did the calibrations, others did not. And the examination setting, or where the examination had been done, is also variant. Some of them were conducted in hospitals, in dental schools, in dental clinics, in schools. So it's wildly variant. This is also his list. Applying these differences on the studies conducted in Saudi Arabia, we can find that the prevalence ranges from 8.6, as low as 8.6%, to as high as 40.7%. They all the studies, they use the criteria of the European Academy of Pediatric Dentistry. The sample size was also variant from as low as 267 to as high as almost 1,000. The age in years is also variant. Some of them, they selected the population, others did not. All the studies were conducted in cities. The study of Rizk et al., it was conducted in 7 cities in Al-Qasim region. As we have mentioned, all of them, they were conducted in cities. All of them, they calibrated the examiners. And regarding the examination setting, some of them, they were conducted in schools, in the dental clinic, or in the dental clinic, or both. So summarizing these differences, the differences are related to the sample size. It was suggested to have a minimum of 300 subjects for prevalence studies and 1,000 subjects for etiological studies. We have differences due to examination site differences, the age of the subjects. The ideal age to perform MIH examination is 8 years of age, of age. The examination protocol, there's variation. Some of the studies, they did the examination while the teeth were wet, in accordance with the guidelines of the European Academy of Pediatric Dentistry. Others, they examined the teeth while they are dry. Some of the studies, they used the daylight, others, they used artificial light. Even the size of the lesion to be recorded is variant. Some of the studies, they included only lesions of 2 millimeters in diameter in size. Others, they did not specify the size of the lesion, but the European Academy of Pediatric Dentistry recommends only inclusion of the lesions of 1 millimeter in diameter to be included. Regarding the eruption status of the teeth to be included, some of the study, they excluded any partially erupted teeth. Others, they included all the teeth, and some studies, they only concentrated on the 12 index teeth, which are the first permanent molars and the maxillary and mandibular incisors. Some of the studies, they excluded the teeth affected by extensive caries. Other studies did not. Some of the studies also, they included other defects. And as I have mentioned, the number of teeth included in the examination is also variant. Regarding the number of examiners and their calibration also is different among different studies. Some of them, they did not calibrate the examiners. Others, they did calibration using photos, standardized photos. And some of them, they did the calibration using subjects not included in the sample of the study. Other differences are related to the diagnostic criteria. Some of them, they used the developmental dental enamel index. Others, they used the modification of the developmental dental enamel index. And some of them, they used the criteria of the European Academy of Pediatric Dentistry. And few of them, they had their own indices. This is the index of the modified developmental dental enamel index. And these are the criteria of the European Academy of Pediatric Dentistry. Other differences are related to the area. Is it rural or urban, in cities or otherwise? Is it a study to be generalized on the whole population? Is it a nationwide or it's on a specific area? So from the previous differences in prevalence study, we have to shed some light on certain issues. Do we need to modify the term MIH, Molar-Incisor Hypomineralisation, since as we know, more than the 12 index teeth could be involved, the second primary molar, the permanent canines, and the premolars. So if we don't include these teeth, we might have an underestimation of the real problem and the magnitude of the problem. During the meeting of the European Academy of Pediatric Dentistry in 2014, they raised the issue for the need of standardization of prevalence studies. Following that, Dr. Al-Ghanim and her working group, they published a study and they suggested a practical method to be employed in order to standardize the prevalence studies. Furtherly, they published another study to effectively use the index and the clinical manual that they have published. They developed two forms, a short form and a long form. The short form includes only the index, the 12 index teeth. The long form includes all the present teeth. We should, for each tooth to be scored, we have to score the clinical status, which we get it from this index, which was developed by them. They combined the modified developmental dental enamel index with the index of the European Academy of Pediatric Dentistry. They score the teeth from 0 to 7. The areas shaded in gray, these are further subdivisions to be recorded in the short form. They start from 0, no visible enamel defects, 1, visible enamel defects, but it's not MIH, it could be diffuse opacities, as in fluorosis, hypoplasia, amelogenesis imperfecta, and hypomineralization, but it's not one of the index teeth. If the for example, the permanent canine is affected, it falls within this score, 1-4. The second score is well-demarcated opacities. Furtherly, we categorize them 2-1 and 2-2 according it's white, creamy, or yellow-brown. Then the third score is the presence of post-eruptive enamel breakdown due to occlusal forces, and we have loss of enamel. Atypical restoration in a patient who is, for example, caries-free, and he has these white opacities in the anterior teeth, and we have a large restoration in a posterior teeth. So this is called atypical restoration, or a restoration which is extending to surfaces which are not prone to dental caries, like the middle of the facial surface, for example, areas that they are not retentive for a plaque. Atypical caries, and 6, atypical extraction. As we have mentioned, in a patient who is caries-free, but he mentions a history of having his 6s badly broken down and they were extracted. 7, in the teeth which cannot be scored due to extensive caries. In the cases where MIH is diagnosed, we have to furtherly list the lesion extent. Is it 1/3 of the tooth, 1/3 to less than 2/3, or 2/3 and more? And we have to list the eruption status. If less than 1/3 of the tooth is erupted, we just categorize it as A, no need for scoring. If it is 1/3 of the tooth is erupted, we list it as B. The previous index was tested for validity and reproducibility, and researchers indicated that codes and definitions were clear and suitable for international use, and it was tested and it is reliable and valid. Regarding further details on how to apply the guidelines, they specified the steps and the techniques to be used. So they recommended to have a minimum of a trained examiner and preferably an assistant with him. If it's not available, to use voice recorders, to, of course, follow the standard infection control protocol, preferably to use disposable mirrors and explorers. Regarding the position, the ideal situation is to examine the subject while he's on the dental chair for better visualization. If this is not available, the subject should lie flat, comfortably, or sitting on a dental chair, or if he's young, to do a knee-to-knee examination. The teeth should be properly cleaned, to use non-magnifying light source and ball-ended explorer. We should be systematic in the recording. We start from the upper right side, going to the midline, then the upper left side, going to the lower left side, midline, lower right side, to avoid missing any of the teeth. We should, as we have mentioned, record the following: the clinical status from this index, and if the teeth are diagnosed with MIH, which means they follow in the category from 2 to 6, we have furtherly to record the defect extent and the tooth eruption status. And also, we have to mention if they are mildly or severely affected. Mild, which means without the post-eruptive breakdown; severe, with post-eruptive breakdown. Regarding the calibration of examiners, which is very important, they suggested a set of standardized photos to be viewed in standardized condition, meaning in the same situation, the same lighting, the same brightness of the computer, and rate the photos 3 times at least, one week interval between them, and repeat the examination for the same examiner to have intra-examiner reliability, and for different examiners to have inter-examiner calibration. And the results, the scores should be entered in a digital system and should be above 0.81. This is an exercise for scoring. Picture number 1, if we want to score it, we have an enamel defect. It's diffuse, it's affecting all the teeth. So we have an enamel defect, but it's not MIH, it's not well demarcated opacity. So it is 1 for the short form. For the long form, we furtherly categorize it as 1-1. And we don't need to score the lesion extent or the eruption status, since it's not MIH. Regarding photo number B, we have an area deficient in enamel. We don't have enamel, so we have an enamel defect again. This is categorized as 1 for the short form. For the long form, this is considered as hypoplasia. And again, we don't need to categorize according to the extent of the lesion or the eruption status. As we have mentioned, it's 1 for the short form, 1-1 for the long form, and for B, 1 and 1-2. Regarding this picture, we have atypical restoration, which is 4 for both the short form and the long form. And since it falls within the categories from 2 to 6, we furtherly score it for the lesion extension, which is about half of the tooth is involved. So it is 2, and the tooth is erupted, so it's B. So for both short and long forms, it's 4 and category 2. This is the last picture to be scored. This is a bit tricky because we are depending on the picture to diagnose the tooth. We don't know, is it a discoloration or the enamel is deficient? And we cannot see the 6s to say this is MIH or not. So we can categorize it as enamel defect, but not MIH. It could be hypoplasia. And also we can categorize it as well-demarcated opacity. Furtherly, we have, as we can see, this is yellow, and here it's creamy white. Usually when we have 2 lesions, we categorize it according to the more severe. So we categorize it as 2-2. And since it falls between the 2 and 6, The lesion extent is about more than a third of the tooth, so it's 2, and the tooth is more than 1/3 erupted. This is for the short form and for the long form. So in conclusion, we have a great need to standardize the prevalence of the studies to know the magnitude of the problem. Do we have to be concerned or not? And to conduct nationwide studies that represent the population on which we are working, to know how to plan and design preventive and treatment programs, and to conduct longitudinal studies to know is the problem increasing or decreasing. For example, we conduct the study for the same subjects at the age of 6, then 2 years later at the age of 8, 10, and so forth. And we should include more than the 12 index teeth. And we include studies that combine not only the prevalence, also the etiology of the problem to properly address it and to design programs to solve this problem. Thank you. Any questions?
Thank you, Dr. Shaima, for this informative lecture. The references, if anybody is interested to see the references, Dr. Shaima listed the references between her slides during the presentation. And okay, before we go to the questions of the audience, I have one question for you, Dr. Shaima. From your points of view, what are the future studies that can we conduct regarding MIH in Saudi Arabia?
Well, we need to conduct a prevalence study which represents the society. We need collaboration between different ministries, the Ministry of Health, the Ministry of Defense, and to conduct a study in collaboration. We can do it as we are doing prevalence studies for dental caries, for MIH as well. And we should also do prevalence studies to correlate between the etiology and the problem. We should know the magnitude of the problem, what are the reasons behind it, and how is it affecting the prevalence of dental caries.
So what do you think the limitation that we can face during conducting such studies?
Well, we need collaboration between different sectors, as I have mentioned. It needs a team, our Saudi Society of Pediatric Dentistry. We can initiate a work group to start this initiative, and we start a prevalence study that could be generalized. We start with the main cities, and then we can include the whole regions, and we can have numbers that we can generalize it on the whole population.
So can you please tell us one of the cases that you treated for MIH? What are the treatment modalities you use from your clinical experience?
Okay, well, this is going to be discussed in the lecture of Dr. Isra, but from what we have seen on daily basis, we see MIH cases with wide range from patients who are already suffering from dental caries, and this is exaggerating the problem. When they have dental caries, but the sixes, the patient comes at the age of 8, with the sixes, they are hopeless and they need to be extracted. Some of the cases, no, we go for stainless steel right away. We cover them with stainless steel. Sometimes the patient, they are caries free and they have very good oral hygiene, but they complain from headache or sensitivity. So this could be related to this problem. They are having MIH and they are unaware because the teeth, once they erupt, they start breaking down, especially in severe cases.
I really like the clinical pictures you address regarding the scoring of MIH. I just want to ask you, how can we generalize the criteria for diagnosis MIH regarding different cities in Saudi Arabia?
We have to use the same index, whether is it the index by Dr. Ghanem and her working group, or the previous indices. There's nothing wrong to use the previous indices, but we should use the same criteria and apply them for all the studies in order to compare them, to be comparable and to have comparable results. We don't want to have this wide range of conflicting results.
So I have one question here from one of the audience. Do we have any early predictors that may help in definitive diagnosis of MIH and its treatment?
We don't have a definitive predictor. The problem with MIH that we don't have a cause and effect relationship. We have risk factors. We have in certain indicators. We are supposed to take a medical history from each of our patients. So if the mother mentioned that she had problem during pregnancy or during delivery or in the first 4 years of age of her child, this is an alarming sign. This is one thing. Another thing, if we examine the ease or the second primary molar and we find the hypomineralized defect, this is an alarming sign and we have to notify the parents and keep the patient under follow-up. So whenever the sixes erupt, we prompt with the management.
I have one question here regarding the education. The audience say, can you please highlight more about the etiology of MIH so we can prevent it by counseling the pregnant ladies? How can we educate the pregnant ladies about that?
The pregnant ladies should be aware that anything that they eat, their behavior during pregnancy, it's not affecting them alone, it's affecting their kids. And as we keep educating them that they should manage their dental condition before even conceiving, the same thing applies to MIH, that any problems, some of the problems, they are unavoidable. Like the mother, she had complications during delivery. It's unavoidable, but at least we should inform them, visit the dentist as soon as possible so we can, as early, manage the case and diagnose it. This is the most important thing to be stressed on.
I have one question from Dr. Hanadi Lunjawi. Do you think that researchers should include a younger age group, 7 to 9 years, rather than 9 and above?
Yes, it's recommended to start for the screening of MIH to start it at the age of 5 to diagnose the second primary molar if it's hypomineralized. But it's my own opinion, it's not scientific. We should start it earlier because if the tooth, the second primary molar in a country like our country where the prevalence of MIH is the prevalence, of dental caries is very high, by the age of 5, the E will be destructed and extracted. So we should start early to screen them, but the recommendation is to screen the second primary molar at the age of 5 and the first permanent molar at the age of 8 before the destruction and the consequences, sorry.
Do we have any index to categorize the severity rather than the clinical status of MIH?
We have lots of categorization and lots of systems. As I have mentioned, the MIH is a hot topic and it had been discussed widely within the past 20 years. The simplest categorization is mild and severe. Mild without post-eruptive breakdown and severe with post-eruptive breakdown. So usually the mild cases, we treat them more with prevention. With post-eruptive breakdown, we go to restorative treatment, unless it's an anterior and we have aesthetic concern and sensitivity. So usually this is what dictates our plan of treatment.
So I have one question from Dr. Abdelaziz. Do you recommend to use the silver diamine fluoride for the treatment of hypoplasia?
Silver diamine fluoride is used more with dental caries. I'm not aware. It could be for the management of hypoplastic lesions or I don't know. No, I'm not aware of this kind of use.
So I have another question. Do you think that MIH patients, how can we touch, they suffered from sensitive teeth, so how can we touch them if they are not getting anesthesia?
Well, this is gonna be discussed in the lecture of Dr. Isra. We have a lot of techniques to be used. We start by using a rubber dam. Regarding the local anesthesia, we have certain types of local anesthesia that works with these patients, and we keep saying prevention. Usually what we do is caries control without using handpiece. Do caries control, temporize all the teeth with glass ionomer. This will minimize the sensitivity, and I'll leave the rest of the management to Dr. Isra.
Yes, agree. So, and I think from my point of view that we have to focus on prevention. We have to educate the communities regarding the prevalence and the etiology of MIH. So from your from your personal opinion, what strategies we can conduct in our society regarding the community education regarding MIH, starting from schools or
as I have mentioned, the mothers, they should know that anything that happens to them, this is an alarming sign that the teeth might be affected. You don't want to scare them, but they should know about that. And this is part of the preventive protocol for the mothers. And we should educate them to come to visit the dental clinic as soon as possible. This is of great importance to apply the preventive protocols on them.
From your personal view as well, do you think that the general dentists, if they take enough experience, can they categorize, can they diagnose the MIH, or they have to be specialists or consultants in pediatric dentistry?
No, you don't have to. The general dentists, they have enough knowledge to know what is hypomineralization, what is hypoplasia. If they attend the didactic courses and lectures, they can know about that. And from my personal opinion, they should know, because we have high number of MIH cases, and they might be the first line to discover them. Maybe in the management, they won't be, they won't have enough confidence to manage them, but regarding the diagnosis and to discover them, they might be the first to discover them and to apply the preventive strategies.
Thank you so much, Dr. Shayma, for this presentation. I will give the mic now to Dr. Saad Al-Mania to introduce the second speaker.
Thank you, Dr. Landa. Thank you so much, Dr. Shayma, about your interesting topic about the prevalence of MIH. And I liked what you said about the collaboration and research between different sectors in the kingdom to have a very really solid data about MIH in Saudi Arabia. Thank you so much, Doctor. Now we'll go to the other talk delivered by Dr. Isra Al-Sharif. The topic will be emphasize the importance of early management of MIH with pediatric patients. And also it will also will emphasize on the possible treatment options of MIH. Now the mic for you, Dr. Isra, and wish you all the luck.
Bismillah ar-Rahman ar-Rahim.
All right, Doctor, you can share the screen. Thank you.
Shared?
Yes, thank you. And slideshow, please.
Okay.
Thank you.
Bismillah ar-Rahman ar-Rahim. First of all, thank you. I have the honor to participate in this scientific day. I'm Dr. Asra Al-Sharif, consultant of pediatric dentistry, working in King Fahd Armed Forces Hospital. Today, I'm going to represent the role of pediatric dentists in the management of molar-incisor hypomineralization, MIH. The molar-incisor hypomineralization is developmental and qualitative defect of enamel mineralization due to systemic factors affected 1 to 4 of permanent first molar and frequently associated with permanent incisors. It can also be observed in second primary molar, tips of permanent canines, and second permanent molars and the premolar. Incisor enamel defects are frequently quite extensive and most common in the labial surface of the teeth, giving rise to cosmetic concerns. As Dr. Shayma said, the best age to examine these patients at the age of 8, where most of the index teeth erupted, and the examination should be on the cleat-width surface of the index teeth, and the size of the defect should be at least 1 millimeter to be recorded. There are several ways to classify the molar incisor hypomineralization. One of them is the modified developmental defect of enamel, giving it 2 digits that describe the extent and the type of the lesion, whether it's demarcated, white or cream, yellow or brown, diffuse opacities in form of lines, patchy, confluent patchy and staining with loss of enamel, or hypoplasia in the form of pits, missing enamel, or any other defect, giving it a code from 1 to 9 in ascending order. And the extent of the lesion, the code will be 0 if it's less than 1/3, more than 2/3, more than 1/3 but less than 2/3, the code will be 2, and more than 2/3, the code will be 3. And the letters that describe the combination of lesion, if it's demarcated or diffuse, demarcated and hypoplasia, diffuse and hypoplasia, or the D if is combination of all the previous defects. It also classified by Mathu-Muju and Wright to mild, moderate, severe. The mild if demarcated opacities are in non-stress bearing area of first permanent molar. No enamel loss is present in opaque area. No dental sensitivity. No caries associated with affected enamel with or without mild incisor involvement. The moderate type, it shows intact atypical restorations. Demarcated opacity are present in occlusal or incisor 1/3 of the teeth. Post-eruptive enamel breakdown with or without caries that is limited to 1 or 2 surfaces, without cuspal involvement. No dental sensitivity, aesthetic concern are frequently expressed by the patient or parent. The severe type, it shows the post-eruptive enamel breakdown. There is history of dental sensitivity. Widespread of caries is associated with affected enamel. Crown destruction can readily advance to involve the dental pulp. Defective atypical restoration is present, and aesthetic concerns are expressed by the patient or parent. Other classification by Malini, degree 1, mild, is isolated white and cream to yellowish brownish discoloration on the chewing surface or upper part of the crown. Degree 2, moderate, yellowish brown enamel affecting more or less all the top of the crown with a slight loss of substance. Degree 3, severe, large-scale mineral deficiency with distinct yellowish brown discoloration and defect in crown morphology resulting from extensive loss of enamel. Here is the diagnostic criteria that given by European Academy of Pediatric Dentistry in the form of demarcated opacity, any aberration from the normal translucency of the teeth, whether it's white, creamy, yellowish, or brown discoloration. Usually this enamel have normal thickness, but the mineralization is deficient, or enamel disintegration in the form of the post-eruptive enamel breakdown. This enamel show the porosity with less hardness, low modulus of elasticity, and this is aggravated more by the occlusal forces or by trauma. Atypical restoration that usually don't conform to the size and shape of regular restoration. Tooth sensitivity, whether it's mild or spontaneous. Extracted teeth, if the extracted teeth due to MIH can be defined only if other index teeth revealed demarcated opacities, otherwise it's not possible to diagnose it. And erupted teeth, if the index teeth have not yet erupted and it's exceeding the chronological time markedly. So the management of the pediatric patient who exhibit signs of molar-incisor hypomineralization, starting by risk identification by taking detailed past history for the pregnancy and the delivery of the mother, and after the delivery by 4 years, and also identify if the presence of any sign of hypomineralization in the second primary molar. Early diagnosis, once it shows any sign of the opacities or post-eruptive enamel breaking down, desensitization and remineralization, prevention of caries and post-eruptive enamel breakdown, restorations or extractions, and maintenance. One of the options is to enhance the prevention and enhance the remineralization and minimize the sensitivity. We can use the casein phosphopeptide amorphous calcium phosphate. This increases the saturation of saliva with calcium and phosphorus, and which bind firmly to the biofilm, and it increases in saturation that penetrate to the subsurface and to the body of the lesion. It usually used at the early stage of eruption in not completely matured surfaces, and it comes in different commercial form: tooth mask that contain 10% casein phosphopeptide amorphous calcium phosphate, MI paste that contain 10% casein phosphopeptide amorphous calcium phosphate and 0.2% sodium fluoride, enamel on treatment gel that contain 970 parts per million of fluoride, and casein phosphopeptide amorphous calcium phosphate that has similar mineralization effect compared to the product that containing 5,000 parts per million of fluoride. It comes in form of tooth cream, lozenges, and chewing gum. But it's contraindicated in patients who are allergic to milk because it contains casein. And Passini et al. Found significant improvement in tooth sensitivity after the use of tooth mask and recommended a mild sensitivity. Here is the tooth mask and MI paste that contain also 0.2% sodium fluoride, and the Novamin that contain very fine bioglass particulates around 18 micrometer, and it has better effect than the tooth mask. How it works? It contains the calcium, sodium, and phosphosilicate, which are the natural elements that found in the healthy tooth and bone. It acts by increasing the pH that promote the hydroxyapatite formation by react the saliva with the sodium, and the pH reach up to 8 to 8.5%, and increase the mineral release by increase the calcium and phosphorus, and saturating the saliva with ions that is important for remineralization and help to build the hydroxyapatite crystals. The demineralized lesion attract the calcium and phosphorus ions where they build the new hydroxyapatite crystals. And also it kills the bacteria because the sodium and calcium cause the cytolysis or the programmed cell death of the bacteria by changing the osmolarity. The fluoride varnish, which is considered the richest source of the professionally applied fluoride, the 5% sodium fluoride contains 22,500 parts per million of fluoride. The Fissure Sealant can be applied in the mildly affected teeth when it's fully erupted, and adequate moisture control can be achieved when the teeth show intact enamel with good hardness and its caries free. But the hypomineralized enamel compared to the sound enamel had many problems. It contained 3 to 15 folds higher protein contents compared to the normal enamel. Most of them is albumin, not amelogenin. And the affected enamel has at least 20% less mineral content compared to sound enamel. It's less in calcium and phosphorus and high in carbon, which prevents the proteolytic enzyme like the matrix metalloproteinase enzyme. And it shows the unfavorable etching pattern, pattern 3. And to improve the retention, the pre-treatment with deproteinizing agents such as sodium hypochlorite or papain-based papacary gel or total H2 adhesive system technique before the application of the Fissure Sealant to improve the retention. And it's important to monitor the Fissure Sealant to be maintained for a long time and avoid deterioration of the underlying tooth structure. In case if the moisture control cannot be properly achieved or the tooth is partially erupted with minimal post-eruptive enamel breakdown, the glass ionomer cement can be used, and should it cover entire occlusal surface up to the cuspal level. If the restorative treatment is the option or the extraction treatment is the option, there are several challenges that face the pediatric dentist to manage such a child. There is difficulty in achieving profound local anesthesia, behavior problems, bonding difficulties, determining cavity borders, selection of appropriate treatment, age of the patient, and aesthetic concern. The hypomineralized enamel is considered poor insulator due to subclinical inflammation due to ingress of bacteria in dentin, sensitivity, and hyperstimulated nerve endings, which lead to minimize the pain threshold and decrease the pain threshold. How we can overcome this problem? By using infiltration anesthesia with articaine 4% that shows more profound anesthesia than lidocaine 2%. Although the articaine 4% is effective as the lidocaine 2% in inferior alveolar nerve block. Buccal infiltration with articaine 4% as adjunct with inferior alveolar nerve block with lidocaine 2%. But why the articaine is producing more efficient anesthesia compared to the lidocaine? The articaine is the only amide local anesthetic drugs that contain thiophene ring instead of benzyl rings. And this leads to increase the lipid solubility in the phospholipid bilayer membrane of the cell membrane. And also it has the high protein binding affinity. Because of the high lipid solubility, it can easily penetrate the phospholipid bilayer of the cell membrane and attach to the inner cavity of the voltage-gated sodium channel and prevent the influx of the sodium and prevent the axial potential. And this is prevent the nerve conduction and the pain. We can also increase the pain threshold by using the inhalation anesthesia or use adjunctive local anesthesia like intraosseous or intraligamental anesthesia after infiltration anesthesia, or use the rubber dam to cover the unanesthetized teeth to minimize the sensitivity and minimize the pain and discomfort that caused by the air or water. Use desensitizing toothpaste before restorative appointment. And Faye recommended the application fluoride varnish at pre-restorative visit, and saliva ejector can be used rather than the high volume suction to minimize the discomfort. In case of the uncontrolled behavior, general anesthesia is the treatment option. Why most of the children that show sign of molar-incisor hypomineralization has difficulty to control their behavior? The children with the molar-incisor hypomineralization need frequent dental visits, and they are at 10 times more than the children with normal dentition in the need of the dental visit due to the post-eruptive enamel breakdown and satisfactory fillings. And a hypersensitivity that leads to avoid the tooth brushing and lead to the caries, and this is worse than the problem. And the affected molars are at 10 times of risk of developing caries if they are severely hypomineralized. And the choice of the best restorative intervention or material is governed by several factors, like the extent of defective enamel, quality of both defective enamel and unaffected parts of the tooth, the presence of sensitivity, and the age of the patient. Restorative treatment option of hypomineralized permanent first molar: resin infiltration, glass enamel restorations, composite restoration, full or partial coverage extracoronal restoration. The resin infiltration is known as erosion infiltration. It removes the relatively intact surface layer and opens the channels to infiltrate to the body of the lesion by using very low viscosity resin, which is capable for penetrating the demineralized enamel. It can be used also in incipient caries or caries white spot lesion, reaching up to outer third of dentin. The only system that's available in the market is the Icon system, which consists of Icon H, 15% hydrochloric acid for 2 minutes, the water rinse for 30 seconds, then Icon Dry, 99% of ethanol for 30 seconds, then Icon Infiltrant, which is methacrylate-based resin, and light curate for 40 seconds. It has several advantages when it's used in the posterior teeth. It improves the micromechanical properties by increasing the hardness up to 15% and decrease the post-eruptive enamel breakdown, improve the retention of composite restoration. It can act as a fissure sealant and not interfere with occlusion or being broken by occlusal forces if it's placed on cuspal incline. And it infiltrates more in severe MIH. But it has the following disadvantages: limited strength, not more than 15% increase in the hardness, require good isolation, not bioactive, and not suitable to the mild or deep lesion, because the molar-incisor hypomineralization usually started at the dentino-enamel junction and the inner third of the enamel below the intact upper 2/3 of enamel. The amalgam is not recommended. It's not adhesive, and it have poor retention in shallow cavity, and it requires certain geometrical cavity outline, prone to marginal leakage, offer no mechanical support of adjacent tooth structure. It acts also as poor insulator. The glass ionomer restoration, it can be used as interim restoration that have soothing effect on the hypersensitive pulp that allow for subsequent shorter and more comfortable dental visit, easy to handle, bond chemically to tooth structure, has an advantage of fluoride release, support the remaining tooth structure, prevent further enamel breakdown, and caries development. Here is some cases that restored with the glass ionomer restoration. The resin-modified glass ionomer can be used too. It has better wear resistance, better handling properties, and better fracture resistance. The resin composite can be used as definitive restoration when the defective enamel is confined to one or two surfaces without cuspal involvement, and it has usually we place the supragingival margin and exhibit good wear resistance. It can be used solely or in sandwich technique after temporization with the glass ionomer cement, but it's technique sensitive, good moisture control, and rubber dam, and need long placement time. The structure of hypomineralized enamel after acid etching with phosphoric acid under the scanning electron microscopy, it shows minimal interprismatic dissolution, little intercrystal porosity, limited microtag formation, and weakness and crack propagation within the enamel. We can see on the left side the normal and sound enamel that show the rod and interrod enamel. On the left side, we can see the hypomineralized enamel that have disfigured enamel structure in the form of rod and interrod enamel. And after etching, usually there are three etching patterns in the enamel. Type 1, that result in dissolution of the prism core. Type 2, in dissolution of the prism periphery. Type 3, deep etching is not achieved and only the crystals around the prism is partially removed. Type 1 and 2, that provide adequate adhesion, while type 3 is undesirable pattern, and the acid etching enamel affected by MIH may produce surface matching type 3 pattern. Here we can see the type 1 that result in dissolution of the prism core, type 2 that result in dissolution of the prism periphery, and type 3 it's only partial removal of some crystals around the prism periphery. The cavity design is important. The cavity design is important, either to use conservative approach that remove only the soft and damaged enamel and place the margin of the restoration on the hypomineralized enamel after it reach certain resistance with a probe and burr. And on the left side, it's the less conservative approach by removing all the MIH affected enamel, leave the preparation border in healthy tooth substance. And the adhesion to hypomineralized enamel, to improve the bond strength, we have to change the cavity design, enamel treatment with 5% sodium hypochlorite to remove the protein, and resin infiltration to increase the retention to the composite restoration, total H2 adhesive that shows superior result compared to self-etching primer adhesive. Here is a photo that shows the pre and post-operative appearance of molar treated with composite. Other photo. The restorative choice is the full or partial coverage extracoronal restoration. The stainless steel crown is the most commonly used one. It prevents further post-eruptive enamel breakdown, manage the sensitivity, establish occlusal or interproximal contact. It requires little or no preparation and can be done in single visit. Here are some teeth that restored with the stainless steel crown. Other choice is the performed malleable composite temporary crown that come in different sizes, like the ProTemp crown temporization material that can offer good aesthetic options and needs some tooth preparation. The crown will require some adjustment, easy, and can be finished in single visit. Other type of the partial coverage of extracoronal restoration is adhesively returned onlay or cuspal onlay that provide the cuspal coverage and give the operator the flexibility in the placement of restoration margin. It avoids unnecessary proximal restoration, enable accurate supragingival margin, can be made out with material with good wear resistance. But it had the following disadvantages. It's technique sensitive, require accurate impression, and require several visits, and relatively expensive. Here is a photo of the gold retained, adhesive retained cast gold overlay. In the case of the badly destructed, severely hypomineralized molar, the extraction will be the treatment of choice. But the selection of the best time of extraction, this is the crucial point. And the best age for extraction is from age 8 to 10, when the bifurcation of the permanent second molar is formed. Other orthodontic consultation should be done before the extraction of other permanent first molar for compensation from the opposite arch and balance within the same arch. Orthodontic consideration like the crowding, unfavorable skeletal base relationship, and the presence of other dental anomalies like congenital missing second premolar. Here we can see a case of a child that shows the badly decayed lower permanent first molars and the upper left decayed first left molar, and we can see the evidence of the formation of bifurcation on the second permanent molars. Management of enamel opacities on the anterior teeth. There are possible treatment options. Is the microabrasion, macroabrasion, tooth bleaching, edge bleach seal technique, resin infiltration, composite restorations, or veneers. The microabrasion is indicated when the discoloration is limited to outer surface of enamel, especially in the brow mottling. Not more than 100 micrometer should be removed through chemical erosion and mechanical abrasion using 11% hydrochloric acid with pumice. Applied to the enamel with rubber cup or stiff bristle brush for 20 to 30 seconds. It's safe, efficient, and atraumatic method for removal of superficial enamel defect. Some research suggests this technique to remove the hypomineralized superficial enamel layer, followed by application of casein phosphopeptide amorphous calcium phosphate to improve the remineralization and minimize the sensitivity. Macroabrasion is other alternative technique for removal of the localized superficial white spot and other surface stain or defect by applying light intermittent pressure using 12 fluted composite finishing burr or fine grit finishing diamond burr using high-speed handpiece. The air water spray is recommended as coolant and to maintain the tooth in hydrated state to facilitate assessment of the defect removal. Here we can see the macroabrasion using the finishing diamond burr. Also, this case that use the macroabrasion to remove the cervical white discoloration. Tooth bleaching is usually indicated for adolescents, and the aim is to camouflage the white opacity by increasing the overall brightness of the teeth, but the possible side effect is the sensitivity, mucosal irritation. The home bleaching is recommended through the carbamide peroxide into the custom fitted tray. This is the gentlest treatment option for bleaching. And for further protection, combined use of casein phosphopeptide, amorphous calcium phosphate tooth mask, and the bleaching gel is recommended. And the casein phosphopeptide, amorphous calcium phosphate will not interfere with the action of the bleaching gel. The aim of the use is to increase the remineralization and improve the aesthetic consideration. Some authors suggested that the use of casein phosphopeptide, amorphous calcium phosphate for 2 hours daily for 3 months in order to gain the proper remineralization, followed the combined use of casein phosphopeptide, amorphous calcium phosphate, bleaching gel for 2 months to improve the aesthetic outcome. And usually the percentage of the use of the bleaching agent, whether it's carbamide peroxide or hydrogen peroxide to the casein phosphopeptide, amorphous calcium phosphate, from 1 to 6 or 3 to 4, depend on the degree of the demineralization and opacities. Here we can see a case before and after the bleaching. Edge bleach seal technique. This technique suggested by Wright et al. 2002 to remove the yellow-brown stain. the affected tooth should be etched first with 37% phosphoric acid or 12% hydrochloric acid. Then continued application for 5% sodium hypochlorite bleaching gel for 5 to 10 minutes. Then the tooth re-etch and cover with a protective layer such as clear fissure sealant or composite bonding agent. With this technique, the yellow-brown stain can be eliminated, leaving the white mottled appearance, which is more aesthetically acceptable. Here is the technique started from the left side with the acid etch for 1 minute, then wash it, then application of the bleaching agent for 5 to 10 minutes, like the sodium hypochlorite. Then after that, re-etch and place the composite bonding agent. Here is before and after. Resin infiltration. This can improve the optical properties by improving the translucency and therefore improving the aesthetics. The refractory index of hypomineralized enamel filled with water is 1.33, and for the hypomineralized enamel filled with air is 1, and the sound enamel range from 1.26 to 1.65. When the microporosities are filled with infiltrant resin is 1.52. So the hypomineralized enamel that filled with the resin infiltrant is close to the sound enamel. There are two techniques, either to use the superficial infiltration or deep resin infiltration technique. The superficial resin infiltration was discussed previously in the molar, and now I will talk about the deep resin infiltration technique. This technique involves the preparation of affected tooth by intraoral sandblasting device to ensure the infiltration can reach to the full extent of the lesion, and this should not remove more than 5 micrometers from the surface enamel, and after resin infiltration, some composite can be added. And the bonding between resin infiltrant and composite of very good quality. Here's a technique that uses the icon system in the anterior, using icon etch, icon dry, then the infiltrant, and the other technique by removal of some tooth substance. Then apply the resin infiltration. After that, adding the composite. Here's a case of combined bleaching and resin infiltration. Another case that used combined microabrasion and resin infiltration in the maxillary permanent central incisors. Other case that used microabrasion followed by resin infiltration on both maxillary central incisor, but on the left side it needs also composite to improve the aesthetic. Composite restorations or veneers. Composite restoration involve removal of defective enamel using diamond burr to remove about half thickness of the opacity, composite resin buildup using opaque resin to avoid excessive enamel reduction, and build up the remaining using appropriate dentin and enamel shades. Here is some cases that use composite restorations on the top and the composite veneers in the bottom. The composite veneer could be more conservative approach if it can be achieved without tooth preparation. That's no removal of even defective enamel. Here is the case, the tooth was restored without even removal of defective hypomineralized enamel. But the composite has several disadvantages like the discolorations, where marginal fracture, long-term maintenance is required. In summary, for the mild and moderate hypomineralized molar, remineralization, fissure sealant, resin infiltration, or plastic restoration, starting from the glass ionomer, resin-modified glass ionomer, or composite restoration. And the severe form, we can use indirect restoration in the form of the extracoronal, partial or full coverage restoration or extraction. And for the incisor, if it's mild, show mild or moderate hypomineralization, remineralization, resin infiltration, micro or macro abrasion, bleaching, etch, bleach, seal, and composite restoration. For the severe, indirect restoration or composite veneers. Here are the references. Thank you.
Thank you, Doctora. Thank you, shukran, Dr. Isra, for your interesting topics about the role of pediatric dentists and dealing with MIH. I have a couple of questions for you. There is a question saying that how about the behavior management guidance needed to deal with MIH patient, especially in the severe cases? This question came from Dr. Dania Islam.
Yes. First of all, these patients usually have a very sensitive enamel. Okay. In case of severe and controlled behavior, the general anesthesia is the treatment option. But before, there are some tricks to minimize the sensitivity during the treatment. For example, the infiltration anesthesia with articaine for percent is more profound than lidocaine 2% due to its chemical composition. Its high lipid solubility and high binding affinity that lead to the higher and more efficient anesthesia in penetrating the cell membrane of the nerves and binding to the inner cavity of the voltage gated channel and prevent the action potential, which leads to the pain. We can use the rubber dam. So we cover the anesthetized teeth and minimize the discomfort that's caused by the saliva ejector. And the saliva ejector is recommended than the high volume suction to minimize the discomfort. Some authors suggest to use the fluoride varnish in the pre-restorative visit. And also the use of the casein phosphopeptide amorphous calcium phosphate is recommended to minimize this sensitivity.
All right.
The nitrous oxide sedation, it also increases the pain threshold, which is very low in such patients because of the porous enamel, and this is the hypersensitive enamel.
Yeah, and I think if the uncooperative child, the treatment option, as you said, is go more advanced, either GA or
Yes.
sedation. So thank you for your answer, Dr. Isra. And there is another question for you, talking about the extraction option. Saying that what's your thoughts on the school of advocate for extraction as a treatment for choice is crowning in the future and maybe root canal treatment?
Yeah, some of the badly decayed hypomineralized molar, which means that doesn't have a good retention, and it's better that to extract these teeth, okay? But the best time is the age of extraction, age from 8 to 10. But we have to pay attention for the other permanent first molar because there is, we should balance there are two important things to put it in our mind, is the balance from within the same arch or the compensation from the opposite arch for the other permanent first molars. And we have to pay attention for unfavorable skeletal dental base relationship, the presence of crowding, and sometimes the congenitally missing second premolars. So it gives us the future prediction for the amount of the spacing or any orthodontic problem.
Yeah. From my experience, if any orthodontist look at a severe, let's say, badly decayed tooth, the first option for them is extraction. So I don't believe that's going to be the point. I mean, treatment option, because sometimes still we can save the tooth, especially when we have a class 3 patient or class 2. It depends case on case. Thank you for your answer. There is another question, maybe the other part of that question, maybe it's going to be marketing for the company. The question is, I have heard that the infiltration Iconic is not available in Saudi Arabia. Have you ever used it or find it here in Saudi Arabia? Please tell it.
Yeah, actually, when we were in the North Jeddah Dental Specialty Center, I would like to thank Dr. Imad. He brought the Icon system. He can order it online from Germany, but it's very effective in the mild class 2 hypomineralization and also in the hypomineralized molar and incisor, and it shows good aesthetic results too.
All right. There are two questions on the same, on the same interests about using SDF for treating MIH.
It can be used, but it's still under studies. The silver diamond fluoride.
Yeah.
Yeah, the purpose of use it for caries arrest mainly because of a bactericidal effect and it minimizes the sensitivity, but it's not yet approved by the FDA.
Okay. So still there is no enough evidence behind.
Yeah, there is not enough evidence. Some studies that they they give like an introduction for the future study that could be done for the silver diamond fluoride.
Okay, there is another questions about the behavior of the child during the treatment. I think you talked about it, behavior management for such cases.
Yeah, and sometimes temporize it with a glass ionomer that soothe the hypersensitive pulp and minimize the sensitivity. So it allows for more shorter and more comfortable following dental visit. And it works with many patients.
From my experience, doctor, sometimes the patient reach to a stage, which is the severe stage, that could be treated and prevented earlier. I think
Yes.
This based on the education of the parents about the signs and symptoms.
And identify the risk factors and close follow-up is very important until the eruption of the permanent first molar and before the tooth reach the occlusion and show the sign of post-eruptive enamel breakdown.
So the earlier treatment and intervention, the better prognosis always.
Yes.
All right. So from your experience, doctor, what is the most obstacle dealing with the MIH?
Sometimes is to gain the confidence, because usually these children they feel very hypersensitivity and they are fearful to be touched by the dentist. Gradually, until we gain the confidence and improve the relationship between the dentist and the child, then in the beginning, we can start with the fluoride varnish or any sensitizing agent. Then after that, temporization with the glass ionomer. Then finally with the stainless steel crown. And usually they are happy because they become Iron Man and they are happy.
Okay. Doctor, you talked about the home bleaching.
Yes.
Do you consider home bleaching as a conservative with the young children?
No, it's only in adolescents. After age of 14, sometimes they just complain from the aesthetic or discrimination in a school or something like this. But usually in the kids, they don't complain from it. Sometimes the parent asks about what are these white patches on the teeth.
There is another question talking about, do you recommend any crown required for molar hypomineralization? If yes, then which is the best option? I think you talked about different
crown, and we cannot place the porcelain fused to metal crowns in the younger children because the biological width is not fully established and short clinical crown, and the growth is not yet finished, and also the pulp is very large.
Okay. There is a very interesting comments from one of the audience that saying, I believe improving GP's knowledge and skills in diagnosis of MIH is very important, and to minimize the case to go for, to the stage of severe. Yes. Yeah, I do agree with this one. I think one of the role of our society to target, let's say some of the lectures to the general practitioner, because they are the first line in the primary care. I think MIH, one of the topics should be directed to the GPs in the future.
Yeah, and also the dietary counseling. This is the thing that's very important, and give the dietary advice to the parents to avoid the cariogenic or erosive diet and avoid the some of the parafunctional habit is also important. And I forget, I may skip one of the slide by mistake. Also the 0.4% daily use of stainless fluoride is also important to minimize the sensitivity and the hypersensitivity of the hypomineralized teeth.
Doctor, you talked about the MI based.
Yes.
I think it's very difficult to find it in Saudi Arabia. Till now, sometimes you found it with your friends bringing it from the outside the country.
Yeah.
But the dealer here is not making it as. I think we have to order more, so they will bring more product for us. There is another question asking about again the behavior. Yes, I think the behavior, we talked about the behavior, we covered it. There is another challenge, doctor. When you talk about one of the treatment option is the composite veneer.
Yes.
Composite veneer, I think if you have, let's say, the four central and laterals, it's very difficult to have very, or let's say, high-end composites with the patient's behavior. I know doing a composite veneer with someone who's 20 years old is different doing it with someone who's 12 years old. And I think this is one of the challenges for pediatric dentists in the clinic.
But some of the patients, they complain from the discrimination in the school and some bullying that happened. So some children at the age of 12, they accept the idea to place sometimes the composite veneer.
Okay. So from your experience, doctor, the MIH is going to be more sensitive in the molar than central, right?
Yes.
All right. So using articaine is your recommendation to deal with this sensitivity, right?
Yeah.
Or let's say change the pain threshold of the case.
Yeah, it's the articaine is more effective in filtration, but it showed a similar effect to lidocaine in inferior alveolar nerve block. So we can use as adjunctive local anesthesia that can be given, but it minimizes the sensitivity markedly.
Okay. What about, there is another question. What about tooth moss? I think we improve the cases by prescribing it, right?
Yeah, it's cadmium phosphorus.
Similar to the MI base, I think so. Similar to the MI base, right?
Yeah, but the MI paste also contains 0.2% sodium fluoride. The tooth moss, it just contains the cadmium phosphorpeptide, amorphous calcium phosphate.
Do we have a toothpaste that prevents or treats MIH?
It's not treat, but to minimize the sensitivity, there are many products available in the market, like the Sensodyne that contains stannous fluoride and it contains Novamin as well.
All right. Is whole technique advisable for MIH?
In the permanent first molar, no, but if it's the second primary molar, yeah, sometimes we can do it.
All right. Actually, doctor, I'm receiving a lot of, thanks for your lecture, interesting lecture. So I have to convey this one. Some of the audience requesting your email. I think Dr. Linda, by the end of the lecture or the event, she will share both speakers' emails in the screen.
Yes.
Okay. Are the primary canines also associated with MIH?
Mostly is the permanent, not the primary. Because the primary, it usually go through normal attrition. And even if it's the primary canine cusp is affected, usually it undergo through a normal attrition procedure. So we cannot see it, but mostly in the permanent canine tip.
There are no more questions. By the end, on behalf of the event today hosted by the Saudi Pediatric Dentistry Society, I would like to thank you, Dr. Isra, and also Dr. Shaima. And the mic now for Dr. Linda. Dr. Linda.
Thank you so much, Dr. Saad, for this informative discussion with Dr. Isra. I really enjoyed that in this webinar. We talked about the prevalence of MIH in Saudi Arabia and how the severity is that problem in our country. And then in the next presentation, Dr. Isra explained how can we manage this problem. So thank you so much for both of them. So At the end of this webinar, I really would thank Dr. Shaimaa Al-Tayyib and Dr. Isra Al-Sharif for their scientific contribution. Dr. Shaimaa explained about the studies of MIH in Saudi Arabia, and Dr. Isra discussed about the different management techniques that we can use to manage MIH in molars and anterior teeth. My great thanks is also for Dr. Saad Al-Manir. We really honored to have you, Dr. Saad. Thank you so much for moderating this session tonight with me. And I will take this chance to announce for the next webinar, which will be tomorrow, 24 June. We will host two distinguishable speakers. We will host Dr. Anas Al-Salmi. He will talk about the management of cleft lip and palate from the pediatric dentistry view. And also we are going to host Dr. Ahmed Masoud. He will talk about the maxillary canine impaction. So I'm really excited to attend this webinar. And I really invite all of the audience to attend this webinar tomorrow, inshallah. I really would like to announce the website of our society, and also the Twitter webpage. If anybody is interested to know more about our future activities, they can visit our webpage. They can also visit our Twitter page. Also, they can subscribe to our YouTube channel. All the recording of all the lectures are there in the YouTube channels. If you have any concern or if you want to know more about the society, please feel free to write to our society on the email. And also, I would like to invite all the general dentists who want to be a member of the SSPD, or if anybody want to renew their membership, to visit our website and become a member of the society. Last but not least, I would like to thank Kunuz Taj Company for organizing this webinar free of charge for all the audience. And also, I would like to thank the president of the SSPD, Dr. Aziz Al-Johar, the scientific committee, and all the members of the society for their efforts in organizing these webinars. I really wish that you will have a great evening, and I really wish that you enjoy this webinar tonight. Thank you so much. And my last advice, that if you want to return carefully, you have to follow all the precautions. I really wish that God save you and all of your family. Thank you so much, and looking forward to see you, inshallah, in future activities.
Inshallah.
Thank you.
Thank you.